and thank you for joining us for today's webinar, Navigating Legislative Changes, Medicaid Eligibility and Enrollment, sponsored by Elevate Patient Financial Solutions. NAHAM promotes best practices, standards, and subject matter expertise, provides an array of networking, education, and certification opportunities, and enables our members to influence and promote high-quality delivery of patient access services. Just a few of our numerous membership benefits include those things seen on the screen and much more. Our membership is comprised of more than 2,100 patient access professionals across the country, and membership provides the unique opportunity to network with leaders in the field. To get us started, I'd like to introduce our speaker for today, Godlee Davis, Regional President of Eligibility Operations at ElevatePFS. Godlee, I'll hand it off to you.
Good afternoon, everyone. I'm very happy to be speaking with you today. I'll start with just telling you a little bit about Elevate. We have been in revenue cycle management for over 45 years with lots of experience across our leadership team and have over 3,000 employees. And one of the things we're most proud of is being a great place to work because those employees really do make a difference. And so we invest quite a bit in our employees. We're also very proud of our client retention, and we do that because we have great partnerships with our clients, and we endeavor to do that for long term, not just short term. And we believe those two things, really that experience and that client retention, because of those great people, are what makes us the best in class service provider for eligibility services. So today we're going to be talking about the OB3, as some people may refer to it, but the big beautiful bill and the impact on some of the healthcare provisions and some of the impact that that's having on Medicaid and marketplace enrollment. And then we'll discuss, after we go through those things, then we'll discuss some mitigation strategies to help affect those things that are going to be negative. And so we'll try to do some things that will help to mitigate that and not have as severe of an impact. So we'll talk about how we can get there. So when we look at the bill, if we wanted to summarize what were the major impacts of the bill, what things really are we going to see as a result, we would narrow it down to really three things. The first thing is that there are definitely people who are going to lose coverage. And that is because sometimes when you have people who are not in healthcare, making legislation about healthcare, there are unintended consequences that oftentimes the providers end up being the ones who have to hold the bag. Well, in this situation, it's not an unintended consequence. One of the main goals of the healthcare provisions are to reduce the people who are on Medicaid, because those things are actually being used to fund other parts of the bill. The second thing would be just everything is getting harder. They're requiring more verifications. They're requiring that the patients and applicants will have to provide in order to get Medicaid, and they're making more hurdles and hoops for people to jump over and through in order to get coverage. And then the last thing is that with all of those things that they're adding on, they're giving us less time to do it. So that those are the things when you make the process harder and you give people less time to do it, that you generally result in fewer people getting on benefits, and some things that will even result in individuals that will in losing benefits that they are. So when we look at the marketplace plans, which this is the provision that was that had the government shut down, the fact that there was not a provision added to the bill to extend the enhanced subsidies for marketplace plans is one of the things that is currently under discussion. And although the government has reopened, they still have not come to a consensus on this matter. The Democratic Party is supposed to be putting together a proposal that will be reviewed in December, and hopefully they can get bipartisan support to maybe add those subsidies back. But we, at this point, we don't know yet, because the conversations they've been having really were at a stalemate. They had not been able to come up with something that could get the votes. So we're looking at what right now is planning to happen in January. Those subsidies, at December 31st, those subsidies end. And so in January, we won't have the enhanced premium tax credit. And to get an idea of what that looks like, if you go like put your memory cap on and go back to when the marketplace was first initiated, one of the biggest complaints was that the plans were unaffordable. At that time, we still had premium tax credits. We still had cost sharing reduction that were written into that law, but they weren't enough to make it where it was affordable. Then fast forward, the enhanced subsidies and enhanced premium tax credits were added. And that made it so that even people who previously qualified for premium tax credits were able to receive more subsidy. And in some cases, we have many individuals that actually have no premium. They don't pay anything because the enhanced tax credit actually covers it for them. And then for many others, it brought premiums down to reasonable rates, $35, $45, many less than $100. Now what we are anticipating to see is at least a 75% increase. Many people are seeing their premiums quadruple. And so that's going to make it unaffordable for a lot of people. The other piece is that as a result of the bill, there are individuals who previously could qualify for marketplace plans, such as DACA recipients that are no longer eligible to qualify for marketplace plans. And to add insult to injury, with the premium tax credit not, that enhanced tax credit not being available and seeing that increase, it's actually compounded because plans were already set to increase. So you can see across the board, commercial plans, even in employer-sponsored plans, are seeing an increase in cost going into next year. And so those two things together really make a big impact on individuals. So when we look at what's contributing to that increase in cost, a lot of the feedback that's coming from the carriers is that there's increase in their cost, and they don't eat that. Generally, that's going to get passed on to the consumer. And so with the increased use of some of those GLP-1 drugs, I'm sure probably everyone on the call either knows of someone or knows someone that is using either Ozempic and Wegovy. They're seeing a very high cost increase with the volume of people leveraging those drugs. And then labor costs and shortages. It's costing more for people. And so anytime you see those costs go up, then that generally gets passed on to the consumers. The other piece is that there is a concern given, and this is from the carriers, given the changes that we're seeing in Medicaid coverage because of how many people that covers, that people who end up going into the marketplace will be people who need that coverage, and they're expecting that to be people who are less healthy. And so if the people that the insurance carriers are covering are less healthy, that increases their cost as well, which they're of course trying to anticipate that with the increase in their premiums. So let's talk a little bit about Medicaid. Medicaid is one of the largest coverages available currently in the U.S. There are, when you look across the states, almost half of the states have at least 20% of their residents covered by Medicaid. But when you look at who actually gets Medicaid, who is it covering? It's predominantly covering our aged population and our children. When you look at 39% of the Medicaid beneficiaries are children, or 39% of children are covered by Medicaid. 63% of our population that's in nursing homes are covered by Medicaid, because generally Medicaid is one of the only coverages that provides that long-term care coverage as well. While adults aged 19 to 64 it's only about 16% of that population in the US is actually covered by Medicaid. And then one of the other things as we talk about the provisions, that's also important to note, is that the majority of those Medicaid adults that we see on coverage are currently working, either part-time or full-time. About 44% working full-time, about 26% working part-time, which gives you about 70% of the Medicaid adults that are working. So there's a smaller group that is not. So for Many, as I already mentioned, there are a lot of children that are covered by Medicaid, but 4 in every 10 births are also covered by Medicaid. And as I mentioned, that in that adult population, 19 million of them are the working poor. And of course, then we need, the people with disabilities and those in their nursing home. That's a large portion of that group that is supported by Medicaid. So when we look at how that spend then breaks down across those groups, the majority is where we would expect with people with disabilities because they are the ones that have the highest costs. They have given the healthcare needs. But then the second is in that group, the expansion adults with 22% of the cost and over $176 trillion. So let's talk about the provisions that now are impacting Medicaid. And one of the things you'll notice as we go through these provisions is that the largest impact by far is on the expansion population. That is the group that is targeted by the majority of the healthcare provisions. So the first provision is eliminating that temporary incentive for states that newly adopt expansion because they don't want to encourage more states to expand. And that is effective in January. The second thing, we have a little time. It's not effective until October of 2028. And hopefully by then we can get something in place to change that. But for the cost sharing, this is requiring states to implement a cost share, like a copay in place for Medicaid expansion adults. And part of what makes this even more of an administrative burden is that it's not just all Medicaid. It's not just all Medicaid expansion. It's only the expansion adults that have income over 100% of FPL, which means currently when you're looking like on your eligibility verification, there's nothing that tells our patient access folks that what the FPL is for a patient to know. There's nothing on the card today that tells you that, or that gives whether or not there's going to be this copay in place. So there's a lot that the state would have to do to be able to provide that information that providers can use for that, and in the way that they're tracking it. And then on the provider side, now you have a group of people that typically weren't even in kind of that collection workflow that you have to call out separately to be able to make sure we're doing that effective follow-up. So that's something that hopefully, because you're looking at a population generally that does not have it to give, so they're not a very high collectible, balance, and so rather than having to just write off whatever the small piece is going to be, and the administrative burden showing that you made that effort, hopefully we can get that changed before it has to get in. The next provision is on the federal match, and this, at least when the final bill came out, was a bit of a win because the original discussion about the federal match was to reduce it for all Medicaid expansion. In the actual law, what it got limited to just the expansion population for emergency Medicaid. And emergency Medicaid is for non-citizens who are not eligible for full Medicaid. So they only get coverage for emergency services. And so it's something that or there's like concern where it will impact, their ability to live. And so usually that's inpatient stays. There's some ER visits that can qualify depending on what the circumstances were, but it's based on the services that are rendered. In those situations now, for that particular non-citizen population, they're eliminating the federal match, which means that's all going to be on the state to provide that reimbursement. And so we do expect to see a reduction in reimbursement for that group as a result. So now one of the very large policy impacts that you've probably heard much about are the work requirements, or you also hear them referred to as community engagement requirements. And so this requires individuals that are applying for Medicaid to meet at least 80 hours of qualifying activities in the month prior to applying. And so the important thing to note here is that they have to do it before they apply. So if someone isn't already working or already doing something to meet that requirement, we've got a very short window to be able to get them into something so that they could potentially qualify to make sure that that current stay is covered. This is something that was previously attempted to be implemented by several states, and only one, the state of Georgia, still has this in effect, and it was a very, very small group of people that are in their, operating under work requirements on their waiver. But this now is requiring this for the expansion population, which we know is, far more people. So to talk a little bit more about what that looks like, qualifying activities, it could be work, it could be going to school, it could be volunteering, or a combination of any of those things. And so as you can imagine, if you have to verify that you're doing this, you have to provide some sort of verification to the state. There's not a single verification form or format that this is provided in. And generally the states don't have that either. They just require you to provide proof. And this is one of the areas, as a partner, where we really step in when we've worked in places where they've had this before to help facilitate that for individuals, because just figuring out what they need to provide can certainly be a challenge. Now, the work requirements for that population won't apply to everyone in that group. There are some exemptions. And, one of the areas is if they do have children under the age of 14, or they're caring for disabled individuals, then they could be exempt. But generally, when we're talking about the expansion population, part of why they're in that group is that they don't have children. If they're pregnant, or if they are participating in an unemployment program where they're doing the work training, things like that, they'll be exempt. SNAP and cash assistance benefits have already had this implemented. This was one of the other provisions of the bill for work requirements. Theirs went into place sooner than the Medicaid work requirements. So if in that state the patient has already met the requirements for SNAP or food assistance, they actually don't have to meet it again. So they'll use that same requirement to show that they've met it. And then, if someone's disabled, or if they're a Medicare recipient, really if they're over the age of 65, period, they're not going to be subject to the work requirements, because it's only for the 19 to 64 or 19 up to age 65 group that is under expansion. One of the other areas that they had in there as an exemption is medically frail. They did not define it in the bill. It's one of the things that's supposed to be given guidance when HHS releases that, hopefully soon, to the states, so that they have additional detail about how this is supposed to be implemented. We're hoping from a provider endpoint that this is a little more expansive, because when we see people coming into either the hospital or into provider areas, that they're coming in generally because there's some need, and hopefully we can get that qualified there as an exemption. There already a optional hardship exemption that some states will opt in to leverage, and one is inpatient requirements, but these are temporary, so they're not long-term exemptions. You only get that while the patient is still in-house, and then they have 30 days to show that they did meet the requirement. So if you have a patient come in, they're self-pay, and you're applying for Medicaid, it won't keep them from being able to apply if they're inpatient, but it will keep them from keeping their coverage, because if after they discharge, if they don't provide that proof of work requirement, then they will lose it. Another piece is just someone's the victim of some sort of national disaster or declared federal emergency, they can get temporary exemptions for that. And then places where there's high unemployment, where the jobs aren't an option, if they're over a certain rate, having an exemption there. Or if you're outside, if the person is traveling and not in their home community for a lengthy time, they can have some exemption during that period as well. So then we'll talk about a couple more policy impacts. One of the big things that's also impacting the population that is expanded is the redeterminations. So right now we do this annually, and law now will require it effective next year that these renewals will happen every 6 months. So we'll do them twice a year. If you remember, it seems like just yesterday, but it was maybe about a year and a half ago, we ended the the COVID unwinding, where because of the state of emergency that was dictated during that time, they paused redeterminations. And when we did the unwinding, everybody that hadn't had a redetermination, they gave, about a 6-month period for the states to get those completed for everyone. And there was lots of information on the news, communication to patients. They were getting text messages, emails, you kind of saw information everywhere reminding people that you need to update your information, make sure they have accurate information for you so that people don't lose benefits. And with all that communication, if you remember, we still saw bump up in self-pay. People still lost coverage, did not do redeterminations effectively, and people who should have still been on benefits. Every time there is a redetermination, there are people, just because of their ability, we're dealing with some very transient populations. Sometimes they just don't even know that the information comes in the mail. And if their address is not up to date, it doesn't even make it to them, or it goes, they just don't open their mail and don't realize that it's due. And so we have what they call the Medicaid churn, where they just expect a certain percentage to fall off. And often they don't even know that they don't have coverage until they present to us as we get to the provider, and then they realize that their Medicaid's been termed because they failed to do this. So now having to do that every 6 months, with that being the new normal, is definitely going to result in additional people losing coverage. The other piece with that's another area really where we've got to kind of pick up the mantle as a provider perspective to get that information out, because there's not really been a lot of communication about this. And so even as you remember, even with everything we did out of the COVID unwinding, it helped mitigate some of that impact, but not all of it. People really aren't even hearing about it. So oftentimes our patients won't know or expect to have to do that every 6 months. The provision regarding immigrant coverage really is impacting a smaller subset. It used to be that if a person was a refugee or asylee, that they were able to get full Medicaid, not restricted emergency Medicaid. Now it's only if they are refugees and asylees from particular areas are they able to get full Medicaid. All the rest will be limited to emergency Medicaid. But very often, as part of what we do in eligibility enrollment, we very rarely see refugees and asylees that are coming in through that process. That's very, very small percentage. And so don't expect that to be a larger impact on hospitals. And then the other piece is retroactive coverage. So for those, this is impacting now not just Medicaid expansion, although expansion populations are impacted more. If it is a Medicaid expansion application, they will only be able to get retro for 1 month. We used to have 3 months or 90 days for retro. Now that's going to be limited to 1 month if it's expansion, and 2 months for all the other types of Medicaid. So your pregnant women, your age blind, disabled. This is across the board limiting of the amount of time that we have to get our dates of service covered. I have these two provisions here because these are some things that really should happen, but you'll notice the effective date for this first one is not until October 29 that the states have to establish a system. And this is to make sure that people that are deceased aren't still receiving benefits, or people that are getting benefits in another state aren't receiving benefits in your state. These are people that really shouldn't be on benefits, but of course this is one that the bill kicks the can on. You would think this is one of the first ones that you want to. And then the next one, this is a eligibility and final rule was something that was passed several years ago, but it keeps getting delayed. It was to make the process for enrolling in QMB for Medicare beneficiaries, as well as CHIP program for children, faster and more streamlined. And they're delaying that now to October of 2034. So we won't get that enhanced, streamlined process to make things faster. So the next two are looking at how the states typically help to finance Medicaid. So they kind of work together with provider taxes and state directed payments. Provider taxes are just a tax that the state puts on providers. It can be, currently the law allows it to be up to 6% of the net patient revenue for that provider. And so they can, when they make a payment to you, it will have this tax on it that they get to keep, and they bring it back into the general fund that they use to fund Medicaid. State-directed payments is a way that sometimes they're able to incentivize particular types of care, levels of care, or things that require a little bit more cost. And so there are lots of programs, like if they want to incentivize primary care, they may pay a bit more for primary care to try to help encourage that and avoid some of the higher cost of care that comes in the future. And they would do that by paying a higher percentage. Well, now this bill limits the state-directed payments in expansion states to 100% of the Medicare rate, so that essentially they're making the Medicare federal government kind of the most favored nation. They'll have the best pricing. In non-expansion states, though, they're actually able to have that up to 110% of the Medicare rate. And we've got several programs across the country that had higher state-directed payments that got grandfathered in initially, but they're going to have to reevaluate them to make sure eventually that they meet this requirement. So when these two work together, the state can have a state-directed payment where they pay providers, 10% more. And then they could issue like a 10% provider tax, where essentially the provider doesn't get anything different, but the state then gets that money, that 10% money back that comes into the general fund. Well, they also get the federal match on the amount that they paid you. So when they're paying a provider, that extra 10%, they're going to get that federal match on that comes to the state, but then they get to keep all of the provider tax. So that part doesn't go back to the federal government. And that's how they kind of use this to play play the game with the money, a little shell game to increase some of the revenue that they have to help fund other areas of Medicaid. And that will no longer be one of the things in their arsenal to help fund it. So when we look across the board at what we expect, what was expected as far as the savings that this bill would generate because of these healthcare provisions, they're expecting about $326 billion as a result of the work requirements. They're expecting $191 billion as a result of the changes with the provider taxes. Another $149 billion, because of the state-directed payment changes. And then with not implementing the QMB and streamlined process, saving $122 billion. And then with the frequency increase on the Medicaid expansion group to having to do those redeterminations every 6 months, another $63 billion. And so you can see, from those changes, the impact that they're expecting that to have across the board. When you look across, this map is an interactive map that Kaiser Family Foundation has that you can click on the state and see the impact. But you can see the states that are losing the most federal funding are those in the dark navy blue color, and that aligns very closely with the expansion states. So we talked about the impact on the state funding. Now let's talk about how this impacts people. We're expecting, unfortunately, about 14.2 million people to lose coverage as a result of the Medicaid provisions, as well as the impact of reducing those or not extending those enhanced premiums on the ACA plans. And when you look at that number of people, there's a very large number that are impacted in just a few large states. California has about 1.7 million, Florida has about 1.5 million, and Texas has about 1.4 million. When you look at who was, often expansion states were targeted, but you have Florida and Texas and Georgia, which are not expansion states, that are going to have a pretty hefty impact as a result of the Medicaid provisions. But in particular, they're really getting hit by the ACA impact, not extending those subsidies. And so, because of all these changes with Medicaid and people that won't have coverage, you can see this cartoon, you no longer have Medicaid, so they can expect to receive a big, beautiful. And not only does it impact the states financially, just administratively, the things that they're going to have to do, the changes that they're going to have to make. You think about redeterminations, how backlogged they got during that time period, how long it was taking them to process, just having the resources to be able to do that. This is going to be a huge impact. Adding extra verifications, things that they used to be able to do by attestation that patients didn't or applicants didn't have to provide verification of. Someone on the other end has to review those verifications. And so that takes more resource and time that the state will have to provide. And so this is something we do expect that this will result in some additional delays because there was not enough funding in the bill as well to the states to really be able to staff up as much as they would need to for some of these upcoming provisions. So I know I've kind of painted a bit of a doom and gloom picture, but there are some things that we can do to mitigate some of the concern. So one of the first things that's most important is educating our community, educating our patient population. And there are a number of ways that we can do that. But one of the things is just looking at your partnerships, local organizations that you can partner with to get information out, to make sure you're sharing that information with them and that they know so they can share with your patient populations. Many providers already do health fairs, including enrollment events as part of those health fairs to help get people access to coverage, but also including material there that shares information with patients about the changes so that to make patients more aware. The materials that you make available, having them in multiple languages is really helpful. And then leverage some of the things that aren't as costly as printed materials. So leverage if you do have leverage MyChart to send out messages to your Medicaid population, just to share information with the changes that are coming. You can do text campaigns and email campaigns that are with this information to your patient populations that are less costly than sending mailers or printing as many flyers, but making sure we're putting up posters and information, things that to provide it when your CCTVs and in waiting rooms and maybe even in patient rooms, making that information available. And that's ways that we can get the information out to the community and get more awareness of the change, because if patients are more aware, they're more likely to follow through with what they need to do. And then the other piece is just your patient population. You build more trust with them, and that is going to make them more loyal patients that are continuing to come in. And for those patients, you want to make sure that you're able to get them coverage so that both they can get the access to care they need and you can get reimbursed. So one of the next strategies we can take is really streamlining. We're looking at areas that could reduce the revenue that's coming in. If you have less people that are insured and getting that coverage, that will have a financial impact. And so looking at other areas to optimize. One of the things that's really important is being able to know who has coverage and who doesn't. We're expecting lots of changes, so making sure you have strong eligibility verification tools in place to be able to identify that, using predictive analytics to identify people who might have risks or coverage gaps, looking at your claims processing, trying to minimize delays, and things that you can do to collect faster. So if there are, and that kind of goes in line with that eligibility verification, making sure that we don't just push forward coverage that people already had before, because for some of those marketplace plans where people may not pay their premium, it may appear right now in the grace period, but if we're not doing anything to help them get coverage, then they don't pay, then you ultimately wouldn't get paid for those. Just looking at those things up front, and then things that you can do to make your processes any more efficient, then that will certainly help to some of the cost and help mitigate the reduction in revenue. The other piece is then really being involved in advocacy. You're on this webinar today in organizations like NAHAM that you can partner with to help respond to changes, to send information to your local legislators about the impact and what things can be done. We want to make sure that they hear they hear our voice and they see the impact that this is having, so that if there is possibility to get some of these things changed in the future, we can certainly do that. Collaborating with Medicaid agencies, this is some of the things that even when you're looking at the more frequent redetermination, work with them to try to get information on who's coming up for redetermination. And this is inclusive of your managed care organizations that you're contract with for Medicaid, because they have a vested interest in keeping those patients on the rolls. So partnering with them to try to do, to reach out to your members is certainly helpful to keep them on Medicaid. And then, working with really any other advocacy groups that are part of your community, just in helping their causes towards, if they need, they can be part of those health fairs that you're setting up. They can come speak and get more information out about what you're trying to accomplish. And then the other piece is just staying on top of what's happening, what you're doing today by being involved in this webinar. So you want to make sure that because we're expecting there to be more self-pay patients, that you do have a comprehensive medical assistance screening. And this is, of course, we're going to look for Medicaid, but we want to make sure we're expanding, the scope of what we look for. If there are fewer people that are going to be eligible for Medicaid, we want to make sure that we're putting in, a review for additional benefits that could potentially help patients, like disability, marketplace plans, and philanthropic funds. So if they're a person that is even in your expansion states where it doesn't require disability in order to get Medicaid, there's still people by diagnosis that could qualify for disability. That puts them in a different category. If they're disabled and getting Medicaid, now they're in the age-blind disabled category, which does not have the same impacts as the expansion. They won't have the every 6-month redetermination. They won't be subject to the work requirements. So some of those other things, that's a way to help mitigate that. For your individuals, particularly those that are in the grace period, we know when we come in January, people who went from not paying anything in a premium to now having premiums, and it could be $500-600. In that situation, you're going to have some of those individuals that need help applying for marketplace, and that's a situation where it can retro. So making sure that you have, as part of your medical assistance screening, that you've got that as part of the arsenal. And then looking at other philanthropic grants, other funding, that's also part of that comprehensive screening to see if there's other things that can cover the cost of drugs or even cover the cost of copays. And then, really, you're not in this alone. Leverage your business partners, especially those that are best in class, to really help with the complexities that we're getting ready to see as this your Medicaid regulatory shift continues to happen. So overall, just in what we've discussed, we expect a lot of people to lose coverage, over 14.2 million. We're going to continue to see our uncompensated care costs increase. And what they're expecting is increase by $63 billion by 2034. And that results in revenue loss, which right now we're facing up to $25 billion in annual revenue loss. And so we've got to take, strategic measures to help mitigate those risks and work together, because it's now more important than it's ever been.
Thank you. Well, that kind of wraps up for today. So in closing, we would like to give another thank you to our sponsor, ElevatePFS, to our presenter for sharing their time and expertise with us, and to our attendees for your participation today.